Hello, everyone. For today, I will be discussing about antianginal drugs. So, we will be talking about medications which are given for patients with myocardial ischemia. Now, before we start with these drugs, let us try to define some terms. You may have heard of the term angina pectoris. Okay, you can pronounce it as angina or angina. Um, This actually is a principal symptom of patients with ischemic heart disease or myocardial ischemia. It is manifested by sudden, severe pressing substernal chest pain um, that often radiates to the left shoulder and along the flexor surface of the left arm. It may also radiate to the left jaw, left side of the neck. So it is a type of chest pain that is caused by reduced blood flow to the heart, therefore. And more often than not, it is a symptom of coronary artery disease. Angina or angina, also called angina pectoris, is often described as squeezing, okay, or pressure heaviness, or tightness or pain in the chest. Some people may say that it feels like a vice squeezing their chest or a heavy weight lying on their chest. It may be a new pain that needs to be checked, okay, or a recurring pain that goes away with treatment. It is usually precipitated by exercise or excitement or a heavy meal. So, what are the different types of angina? Okay. We have three types actually. The classical angina, okay, or the stable angina, we call it. And then you have the unstable angina and the Prinzmetal's angina or the variant angina. Let's go to the classical angina first. So the classical angina or the stable angina usually develops when the heart works harder, such as when a patient exercises or climbs the stairs. Okay, so it's commonly induced by excitement or exercise or perhaps a heavy meal, and it is secondary to advanced atherosclerosis of the coronary vessels. This is usually associated with ST segment depression, as found on the ECG. Stable angina can usually be predicted, and the pain is usually similar to the previous types of the chest pains that the patient experiences. It usually lasts a short time, okay, perhaps around 5 minutes or even less, and it disappears sooner if the patient rests, okay, or they take their angina medication. So the severity and the duration, okay, and the type of angina can actually vary. So there are other types also of angina, okay, um, and so if a patient experiences something new, or let's say a new or a different symptom, okay, it may signal a more dangerous form of angina, which is the unstable angina, okay, or a heart attack. Thus, we move to the unstable angina. So, um, an unstable angina may involve the coronary spasm and may also have the component of atherosclerosis. And the duration of manifestation is quite longer than the stable angina or the Prince-Metal's angina. And it has the manifestation of myocardial infarction. Usually, an unstable angina will occur even the patient is at rest, It is a change in the usual pattern of angina. Let's say if previously the patient is having chest pains only after exertion or climbing the stairs, okay, and is relieved by rest. But this time, even the patient is at rest, he's still having the chest pain, then you may be dealing with an unstable angina, okay? So it can be unexpected, and it's usually more severe and lasts longer than a stable angina. Some would even say it would last for about 30 minutes or so. And like what I've said earlier, it may not disappear with rest or even by taking uh, the angina medication. So, this type of angina, okay, the unstable angina, might signal a heart attack. So, there's another type of angina which is called the variant angina or the Prince Metals angina. And this type is quite rare as compared to the other two. So it's caused by a spasm in your heart's arteries that temporarily reduces the blood flow. So the pain may be induced while the patient is at rest, okay? Uh, and it's often severe. So it can be associated with ST segment elevation also on ECG. And however, the difference between Prince Metals angina and unstable angina is that Prince Metals may be relieved by angina medication. Okay, remember that this is secondary to vasospasm, okay, of the coronaries, and so if you take your anti-anginal medication, then um, there is a possibility that it will be relieved. Now we said earlier that um, angina pectoris is caused by uh, myocardial ischemia, okay, or poor oxygen supply in the myocardium. Therefore, it would be helpful for us to understand, okay, what factors would cause the or would affect, should I say, the oxygen supply in the myocardium. So let us go through the determinants of myocardial oxygen supply. Okay, so we have um, coronary blood flow, okay, and arteriovenous oxygen difference. So, coronary blood flow is determined by perfusion pressure, by duration of diastole, and coronary bed resistance. So, if there is increased perfusion pressure, then definitely you would have better coronary blood flow. And better coronary blood flow would mean increased oxygen supply or better oxygen supply. Now, what about the duration of diastole? We know that diastole is the period wherein the heart muscle, the myocardium, or the ventricular muscle is relaxed. And therefore, during that time, the coronaries are dilated, and it is the time wherein the coronary would give out its oxygen supply to the myocardium. Thus, if the duration of diastole is a bit longer, then there is more time for the delivery of oxygen, more time for blood flow in the myocardium, thus increasing oxygen supply in the myocardium. What about coronary bed resistance? We know that um, uh, resistance is um, is indirectly proportional to the um, diameter of the blood vessel, meaning if the blood vessel's diameter is decreased, as in vasoconstriction, and coronary bed, or sorry, should I say resistance, is increased. And so if there is increased coronary bed resistance, then you expect to have lesser oxygen supply because the coronaries are constricted. So these three factors determine coronary blood flow and thus also would determine myocardial oxygen supply. Now, what about arteriovenous oxygen difference? Now, although oxygen carrying capacity can impact myocardial oxygen supply, coronary blood flow is the major determinant of supply. And coronary artery blood flow is a function of pressure divided by resistance. So myocardial oxygen consumption is equal to coronary blood flow multiplied by arterial venous oxygen difference. Therefore, if there is increased arterial venous oxygen difference, then you can say that there is also increased oxygen consumption. So during diastole, wherein the ventricles are receiving blood before the systolic contraction of the myocardium, this filling phase, okay, the diastole of the cardiac cycle allows the coronaries to provide maximum blood flow to the heart. And additionally, this is the only phase of the cardiac cycle that allows blood to arrive at the subendocardium, which is the most distal portion of your uh, ventricles. So you can therefore say that myocardial ischemia, uh, which produces angina, results from an imbalance in the myocardial oxygen supply and demand relationship, such as when there is decreased supply of, decreased oxygen supply, then you will have ischemia. And, or if there is an increased oxygen demand, then there can also be ischemia. Thus, angina, which is a symptom of myocardial ischemia, is due to a decrease in oxygen supply and or an increase in oxygen demand. Therefore, if we are to look for medications or to give medications for angina, we would give those drugs which can increase oxygen supply and or decrease the demand for oxygen. So since we're now talking of myocardial oxygen demand, so let us try to understand the determinants of myocardial oxygen demand. The cardiovascular system is an intricately designed vascular network that provides blood and oxygen to the entire body. And myocardial oxygen demand is the amount of oxygen that the heart requires to maintain optimal function. And myocardial oxygen supply is the amount of oxygen provided to the heart by the blood, which is controlled by the coronaries. So, when the body is operating at at its optimal physiologic condition, we say, myocardial oxygen supply does not exceed myocardial oxygen demand. Now, since the heart operates solely under aerobic metabolism, myocardial mitochondria must maintain an abundance of oxygen in order to continue oxidative phosphorylation. So, major determinants would be heart rate, contractility, and wall stress, or we call it ventricular wall tension. So, these are the three factors that determine myocardial oxygen demand. An increase in any of these three variables requires the body to adapt to sustain adequate oxygen supply to the heart. So let's take heart rate, for example. It is thought to be the most important factor affecting myocardial oxygen demand. With an with an increased heart rate, the myocardium must work harder to complete the cardiac cycle more efficiently. With a shortened cardiac cycle, the time spent in diastole decreases. And since diastole ends prematurely, the amount of blood that normally fills the ventricles decreases, and oxygen saturated hemoglobin is not allowed to reach the subendocardium. So, under optimal conditions, myocardial oxygen demand will equal that of myocardial oxygen supply. However, when there is structural damage from, let's say, a plaque or thrombosis that would impede blood flow, there can be a mismatch between myocardial oxygen supply and demand that results in ischemia. What about contractility? Okay, so contractility or inotropism is the rate of increase in the intraventricular pressure during contraction at a given muscle fiber length. Now, interestingly, myocytes have the innate ability to exert a contraction at any muscle length, and this force is measured after the closure of the mitral valve and just before the opening of your aortic valve, during which time the intraventricular volume remains constant. So contractility is impacted by a variety of intrinsic and extrinsic forces, including calcium concentration. Um, why talk about calcium? Okay, it's because when calcium is released by the sarcoplasmic reticulum of your cardiac muscle, it binds to troponin C. I hope you can still remember your physiology. So, this binding of calcium with troponin C stimulates a conformational change of tropomyosin, remember? That releases it from the binding sites on the actin filament. So, with the release of tropomyosin, the active sites on actin are now free to bind myosin, which causes ATP or adenosine triphosphate to be broken down into your ADP or your adenosine diphosphate and in organic phosphate. Subsequently, there is a power stroke. Remember? So there will be a power stroke of the myosin head, which forces the actin filament centrally towards the sarcomere, and ADP and your phosphate or inorganic phosphate will detach from the myosin head, thus resulting to contraction. So once the ATP, or your adenosine triphosphate, reattaches to the myosin, then your actin is freed. And so this cycle continues until intracellular calcium supplies are depleted. So there is no longer binding between troponin C and calcium, and tropomyosin can revert to its initial conformation to cover the binding sites on actin. Therefore, the intracellular calcium concentration is directly proportional to the contraction force. Next, we move on to wall stress, or what we call ventricular wall tension. Uh, it is based on, or should I say, um, wall stress, okay, is based on the thickness of the wall, or of the myocardium, ventricular myocardium. The, I mean, if you can still remember the law of Laplace, which states that ventricular wall tension is proportional to the ventricular radius and intraventricular pressure. Okay, so patients with coronary artery disease will have decreased blood and thus oxygen supply, okay, to the myocardium. Therefore, in this case, contractility will be diminished. So because the ventricle can no longer achieve adequate contraction, therefore the end systolic volume will increase. And the excess blood remaining in the ventricle will cause an expansion of the ventricular radius and intraventricular pressure, therefore resulting in higher wall tension. So I hope that explains it. So therefore, the treatment plan for patients with angina will be to decrease the risk factor like atherosclerosis, hypertension, smoking, because we know that these conditions would even cause more problems. Okay. Of course, next would be to increase the oxygen supply to the myocardium, and last would be to decrease the oxygen demand, so that if in case oxygen supply is not enough, then at least we are at the balance. So now we can move on to the different antianginal drugs. Okay, we have agents which decreases oxygen demand and increase oxygen supply, and these are nitrates and calcium channel blockers. And we also have agents which decreases oxygen demand, such as the beta blockers. Although somehow beta blockers may also increase oxygen supply somehow, okay, indirectly, but they are directly causing a decrease in oxygen demand. So let's go to the, let's discuss about nitrates and nitrites first. Okay, so let's try to classify nitrates. We have rapidly acting nitrates, and we also have long acting nitrates. So, rapidly acting nitrates are used to terminate acute attack of angina. Examples of which would be your nitroglycerin and your amyl nitrate. And these are usually administered sublingually because we know that sublingual route will give you a faster action as compared to an oral route. Now we also have the long-acting nitrates, and these are the ones used to prevent an attack of angina. Examples would be your erythritol tetranitrate, your isosorbide dinitrate, your pentaerythritol tetranitrate, and they are either administered orally or topically. So probably you would ask, how will nitrates help in the treatment of angina pectoris. Okay, so nitrates causes coronary artery dilation or dilatation. And so remember we mentioned earlier that when the coronaries or when the blood vessels dilate, okay, meaning they increase their diameter, then the resistance decreases. Okay, so it's an inverse relationship. So coronary artery dilation will decrease coronary bed resistance. Okay, and this thus, okay, relieves coronary spasm. Okay, so in turn, it will increase coronary blood flow. And when there is increased coronary blood flow, then there will be increased oxygen supply into the myocardium. Now, nitrates also cause dilatation of the aorta, okay? And thus, it reduces peripheral resistance. Again, you have the inverse relationship between the blood vessel diameter and resistance. So, when there is reduced peripheral resistance, there is decreased blood pressure. When there is decreased blood pressure, then there is decreased afterload. Okay, there will be not much force that has to be uh, counteracted by your left ventricle because your blood pressure is decreased. And that will cause a decrease in the workload of your left ventricle. And we mentioned earlier that if there is decreased workload, then there is decreased oxygen demand of the myocardium. Thus, there will be decreased oxygen consumption. So, this is another way of how nitrate would help in treating uh, angina or myocardial ischemia. And not only that, nitrates can also cause a reduce in venous return. Why? It's due to the dilatation of the veins. So nitrates would cause actually dilation of the blood vessels in general. So if there is reduced venous return, okay, meaning not much blood is returned back to the heart, then there will be decreased left ventricular volume, okay, or decreased blood volume in the left ventricle. And because there is decreased left ventricular volume, or what we call a preload, okay, so a decrease in preload will also cause a decrease in workload because there's not much blood that has to be pumped out, okay? So a decrease in workload, again, would cause decreased myocardial oxygen demand and will therefore cause a decrease in myocardial oxygen consumption. So nitrates, in summary, would cause the following: coronary artery dilatation, reduction of peripheral arterial resistance, and therefore a decrease in afterload, reduction of venous return, and therefore a decrease in preload. So as you can see, the potential beneficial effects of nitrates would be a decrease in the ventricular volume, decrease in arterial pressure, a decrease in ejection time, venodilatation of the epicardial coronary arteries, an increase in collateral flow due to venodilatation, a decrease in left ventricular pressure, meaning a decrease in preload due to dilatation of the vein, and a decrease in afterload due to dilatation of the arteries. So, all in all, it decreases myocardial oxygen requirement, it relieves coronary spasm, it increases perfusion to the ischemic myocardium, and it improves subendocardial perfusion. However, Nitrates would also have its potential deleterious effects, such as reflex tachycardia, reflex increase in contractility, and a decrease in diastolic perfusion. So this is a table just to show you some of the nitrates that are available. So we have your nitroglycerin, which can be given as through a sublingual route. Same with isosorbide dinitrate. Uh, amyl nitrite can be given through inhalation. So these are your short-acting nitrates. Now you also have your long-acting nitrates, such as your sustained action nitroglycerin, which can be given orally. You also have your ointment, NTG ointment, which is given topically. And there's also a nitroglycerin transdermal patch. There is also a nitroglycerin which is given through the buccal mucosa. Ascorbide dinitrate can also be given sublingually um, or orally, okay, whichever you need them, you need it. And then you have your ascorbide dinitrate chewable also, and your ascorbide mononitrate, which is given orally. So these are the different routes of administration of nitrates. You have the sublingual route, which is a rational and effective route for the treatment of acute attacks of angina pectoris. And the half-life depends only on the rate at which they are delivered to the liver. Okay, so if you want a faster action from your antianginal drugs, you should give the preparations, nitroglycerin preparations, which can be given through the sublingual route, such as your isosorbide dinitrate. Then we also have the oral route, okay, in order to provide, this can actually provide convenient and the prolonged prophylaxis against attacks of angina. So it's usually given more as a maintenance medication, okay? So, like your acerbide mononitrate, for example, is given as a maintenance medication, okay? It's given orally. And then we also have your intravenous route. It's useful in the treatment of coronary vasospasm and acute ischemic syndrome, okay? Because you want, uh, the drug to be directly given into the bloodstream. And then we also have the topical route, which is used to provide gradual absorption of the drug for prolonged prophylactic purpose. So it's usually the most common is uh, the NTG patch, which is given transdermally, okay, a transdermal patch, um, which is placed in attached in the skin or on the skin, and is usually replaced, every day. Okay, so just make sure that when you give your NTG, you should have a an NTG free uh, period. Now, just like any other medications, nitrates also have its adverse effects, and more, or should I say, most, if not all of these, are usually due to vasodilation, such as throbbing headache, flushing of the face, dizziness, especially at the beginning of the treatment, because the patient is starting to adjust to the changes in the blood pressure, and then postural hypotension because of the pooling of blood in the dependent portion of the body. Remember that there's not much uh, uh, venous return, okay? And so, whenever you give an NTG, uh, do not allow the patient to abruptly, stand into an upright position from a reclining position in order to avoid accidents or falls. Okay. Now, nitrites are not given or contraindicated for patients with renal ischemia, acute myocardial infarction, and patients receiving other antihypertensive agents because of you know what do you call that, potentiating effect. Now let's move on to the beta blockers. Okay, the Beta blockers decreases heart rate and contractility of the myocardium. Thus, okay, due to the decrease in heart rate, the duration of the diastole is increased. Okay, so it becomes longer. And so we said earlier that the longer the diastole, the more time that there will be coronary blood flow, because this is the diastole is a time wherein there is uh, uh, perfusion of the ventricle muscle, of the ventricular muscle or myocardium. So there is increased coronary blood flow, and thus there is increased oxygen supply. Um, Similarly, because of the decrease in heart rate and contractility, uh, beta blockers can also decrease the workload of the ventricle. And because there's decreased workload, there's also decreased oxygen consumption, or a decrease in oxygen demand. So beta blockers decreases heart rate, and it also reduces blood pressure and cardiac contractility without an appreciable decrease in the cardiac output. However, beta blockers are not given for patients with congestive heart failure, asthma, and a complete heart block. Now let's go to the calcium channel blockers. So calcium channel blockers causes coronary artery dilatation, just like what I have explained earlier about the mechanism, the binding of calcium with your troponin C, okay, and the cascade of events, okay, leading to myocardial contraction, or smooth muscle contraction, or muscle contraction. So calcium channel blockers will cause coronary artery dilatation. It will also cause a reduction on the peripheral arterial resistance, and therefore a decrease in afterload. So decreased afterload, there will be decreased workload to the heart, okay, because there is not much pressure uh, that has to be compensated, okay, and a decrease in uh, myocardial workload would mean decreased oxygen consumption. Coronary artery dilatation will cause an increase in blood flow in the myocardium, thereby increasing myocardial oxygen supply. So, if there's coronary artery dilatation, there's a decrease in coronary resistance, and thus increase the coronary blood flow, thus increase in oxygen supply in the myocardium. When there is reduction of or on the peripheral resistance due to the dilatation of the aorta, there will be decreased blood pressure, decrease in afterload, thus causing a decrease in workload of the heart, and therefore causing a decreased oxygen consumption. Calcium channel blockers, however, also has unwanted effects, such as nausea and vomiting, dizziness, flushing of the face, and tachycardia due to hypotension. And these are usually caused by the vasodilatation also. Calcium channel blockers are contraindicated in patients with cardiogenic shock, with recent MI, patient on heart failure, and an atrioventricular block. So most commonly used calcium channel blockers are your nifedipine, your verapamil, and diltiazem. Now, it is not uncommon for patients with angina to receive more than one uh, drug, and we're often uh, having beneficial effects from combination therapy. And um, sometimes you would see patients having nitrates and beta blockers. Okay. And the additive efficacy is primarily a result of one drug blocking the adverse effect of the other agent on net myocardial oxygen consumption. So beta blockers blocks the reflex tachycardia associated with nitrates, and nitrates attenuate the increase in the left ventricular and diastolic volume associated with beta blockers by increasing venous capacitance. There's also a combination of calcium channel blockers and beta blockers, which is useful in the treatment of exertional angina that is not controlled adequately with, nitrates and beta blockers. So the beta blockers attenuate the reflex tachycardia produced by nifedipine, and these two drugs produce decreased blood pressure also. So it's also good for patients with hypertension. Sometimes there are also a combination of calcium channel blockers and nitrates, and this is useful in severe vasospastic or exertional angina, particularly in patients with exertional angina with congestive heart failure and sick sinus syndrome. So the nitrates reduces the preload and afterload, and calcium channels reduces the afterload. So the net effect is reduction of oxygen demand. And yes, it's also possible to have a combination of those three: the nitrates, calcium channel blockers, and beta blockers. So they are useful in patients with exertional angina not controlled by the administration of two types of antianginal agent. So usually you start with just, one and then move on to two drugs. Then if still not working, you can give three drugs. So nifedipine can decrease afterload. Your nitrates can decrease your preload. Beta blockers will decrease the heart rate and myocardial contractility. But please be careful when you give these drugs, especially on the elderlies. You have to watch out for their blood pressure. You have to be careful with postural hypertension, and yeah, more on fall precautionary measures. So this table is just to show you the different types of angina, and the different drug treatment that can be given. Okay, so for stable angina, you could either give nitrates or calcium channel blockers or beta blockers. For variant or the Prince metals angina, uh, you can give nitrates or calcium channel blockers. They're better. And then for unstable angina, nitrates and your calcium channel blockers. Okay, so that's it. Thank you for listening. I hope you have learned a lot from the drugs given for angina pectoris. God bless everyone.